widespread rashes that are pretty benign. Another smaller percentage is urticaria, which we're going to talk about urticaria more in depth next week. But those are and then you've got a small, thank God it's a very small percentage of some of these much more serious, where the skin's blistering, skin sloughing, which are bad news, bad news. You always have to remember age and having a concomitant viral infection such as HIV or Epstein-Barr virus really puts you at greater risk of having a drug reaction. So you're going to learn there's going to be a pattern here. Antibiotics, anticonvulsants, and your non-steroidal anti-inflammatories are some of the worst offenders. And I'm not really getting into this a whole lot, but there are certain drugs that cause certain patterns of rash, okay, like a lichenoid reaction, or an urticarial reaction, or things like that. Rashes that look like psoriasis, psoriasiform reaction or pattern. So sometimes what you can do is if you, that will help you, you could look up, say you get a biopsy and it says a lichenoid like pattern changes under the microscope, then you can, if you're suspicious of a drug reaction, then you can look up and say, okay, what drugs cause a lichenoid reaction, and then that will help you figure out maybe which medication that they're on could have been the problem drug. All right, this is kind of a busy something. There are different types of drug reactions. The main two I want you to be familiar with are the type 1 and the type 4. Okay, and we'll talk about that here in a little bit, or right now actually. Okay, the type 1 reaction is what causes hives or urticaria. That's what urticaria means, is hives. Angioedema, which again we'll talk about in greater depth. Angioedema is a deeper swelling, deeper in the tissue, oftentimes affecting the lips and the eyes or the face, and sometimes the tongue, and anaphylaxis. All those, I want you to know which type of reactions are type 1 reactions. And this can occur very, very quickly, because what happens is you're exposed to a medication one time and your body develops a drug protein complex, and then you're exposed to it a second time, and that's when you have the reaction. Okay, the hives in this type of reaction is due to degranulation of mast cells and the increased release of histamine, as well as some other inflammatory things, but histamine is the big key. So this isn't going to happen the first time you are exposed to a medication, a specific medication, or the offending medication. It's going to be the second or after times that you've been exposed to it. And IgE antibodies are the antibodies that are associated with this. Now, type 4 reaction are your more common morbilliform. That's that widespread, kind of real fine little bumps. That's kind of how you describe morbilliform. A fixed drug reaction, which is, we're going to talk about that here in a little bit. DRESS, we're going to talk about in a little bit. AGEP, we're going to talk here in a little bit. But just know which ones are type 4 reactions. And these have to do with our T-cell lymphocytes. Same sort of thing, but IgE and histamine is not involved. That's your type 1. This tends to be kind of a delayed reaction. All right, so you start your medication today, but it takes several days before you start seeing the reaction, where the type 1 you can see very, very quickly, sometimes within minutes. All right, so the morbilliform reaction is by far the most common, and it's pretty benign. It's uncomfortable, but it's pretty benign. Patients, you know, it kind of freaks out your patients. Bless you. So this can be kind of insidious. It can be sometimes up to 2 weeks after they've stopped the medication. They have very few, to no, systemic involvement. So they're not going to have fever. They're not going to have changes in their blood work, things like that. They're not going to have lymphadenopathy. They just have a widespread rash. And it tends to be more proximal, meaning the trunk, and will extend out from there if it does extend out. Normally, always your drug reactions are going to involve the trunk. Okay, if you've got a heavy extremity rash, or a rash that involves the extremities a lot, more than likely it's not as much due to a drug. So widespread erythematous macules and papules begins proximally and then spreads generally, and it can become confluent. So it'll just be like one big old patch of redness. Very, very itchy. So these people are going to be itchy and uncomfortable. Antibiotics are the biggest cause, especially your penicillins and trimsulfa, your sulfa-based drugs. You're going to hear a pattern with sulfa. Just noting this. Again, especially if you have a secondary viral infection such as HIV, you're going to be at greater risk. So there you are. See how confluent that is? That probably didn't start out that way. They were probably more well-defined, but there's just so many of them that it just turns into one big old confluent rash. And that's the morbilliform. So fine, very small macules and papules. All right, so with this, we need to figure out which medication, probably an antibiotic, and quit taking it. If it's like the gentleman in the previous picture, he's very uncomfortable and itchy and wants to get feeling better pretty quick, so I would probably give them oral steroids, a taper, for sure topical steroids, because that will help calm the inflammation in the skin as well. And you can do both. You can do topical and oral steroids. Antihistamines, especially at night, or the sedating antihistamines at night, such as Benadryl, hydroxyzine, things like that. Your non-sedating antihistamines, such as Zyrtec or Zysol or Claritin, those tend to be less sedating. You might give in the daytime. So this will clear on its own. These others are just kind of helping to manage the symptoms and helping it to give it a nudge to get going faster. But it will clear on its own, within a couple of weeks after you stop that agent. If you keep taking that agent, you're going to continue to have it. Anytime you get, like that picture of that gentleman, I mean, that is so widespread. Anytime you get that much inflammation in the skin, it's expected to get a little bit of sloughing of the skin. Now, not in sheets like blisters that we're going to talk about, but they're going to be kind of scaly, and they're going to need some moisturizing agents just to help with that scale. But again, I think if you can prepare them for that, just say, as this starts to clear up, you're going to get real dry and scaly, so you may need to moisturize. That'll make you feel better, but expect that. All right, our urticaria, or hives, and angioedema. The main lesion you see, the primary lesion you see is a wheal, all right? And this is basically just swelling, localized swelling in the dermis, and it just kind of lifts the skin, very much like a mosquito bite, okay? It just lifts that skin, but that we call a mosquito bite a papular, a small urticaria or hive-like reaction. These are going to be bigger lesions. Angioedema is deeper swelling in the dermis and subcutaneous tissues. And again, that often affects the face and mucous membranes. A little bit, or it's not as well defined as a wheal is. Now this type of reaction, as we learned, can be associated with anaphylaxis. So that can be, if you've got this type of a thing, you need to ask, are you noting any shortness of breath? Is your tongue swelling? You know, anything like that. And if they are, you need to at the very least, give them a prescription for an EpiPen. So kind of remember that. It may not be in here, so I can't recall, but remember that. Again, this is due to mast cell, the generation of mast cells, which puts out lots and lots of histamine. You've got some reaction like this. Your aspirin and your nonsteroidal anti-inflammatories have this kind of reaction, but it's not due to the IgE antibody being associated with that. It's more prostaglandin. So when you have your IgE antibodies involved, an immunologic reaction, that's most commonly associated with penicillin, and it's related, like Augmentin related medication. You can also get another medication that can cause angioedema, are your ACE inhibitors, but that also is not an IgE antibody related thing. That's more kinin levels, and I don't know all the physiology about that. You guys might, but I don't. Just know it's not IgE related. So that is a wheal on screen left, or wheals, plural, and angioedema on the right. See how swollen that lip and eyes are? And that, you tend not to have, you tend to have more burning pain with angioedema rather than itching. Urticaria tends to be horribly itchy, unless if it's like in the palms and the soles, and then it can be a little bit more painful, because you know you don't have a lot of room for swelling in the tissue of your hands and feet, so it tends to be a little bit more painful there. All right, so again, figure out which medication this might be and get the patient off of it. Again, because this is histamine driven, the antihistamine is a must. It is a must. The H1 blocking, the non-sedatings, so that a person can function through the day. Sometimes it's not uncommon to require up to 4 times the normal amount of antihistamine. So for just our routine allergies, we take 1 Zyrtec a day, right? It's a 24-hour. You may need up to 4 pills a day to help control the hives or the urticaria with this. Sometimes a person will add an H2 blocker. We just want to block all histamine, what am I trying to say, sites. So it's very debatable as to whether the H2 blockade really helps or not, but gosh, if you want to throw everything but the kitchen sink at it, then do that. Again, systemic steroids you may want to do for a very widespread involvement, just to get them more comfortable more quickly. It's not going to be a long-term, you know, as soon as that, if you don't get them on the antihistamine, as soon as that steroid wears off, the rash is gonna come right back. And if they're, you know, in the ER and having an anaphylactic reaction, they need epinephrine, but that's for a different lecture. Okay, there's such thing as a fixed drug reaction. Any questions about urticaria, angioedema? Fixed drug reaction is kind of an interesting deal. I didn't even, until I got into dermatology, I didn't even know there was such a beast. But this is usually a solitary lesion. Sometimes you can have more than one lesion, but typically it's one solitary lesion that will reoccur in the very same place every time you're exposed to this offending medication, okay? What's kind of unique about it too is it has kind of a color to it that there's not too many things that have that color. It's kind of a erythematous to violaceous. Violaceous is that purple color, all right? There's not too many rashes that cause a purple color. So if you see one lesion that has this reddish purplish discoloration, you need to think about a fixed drug reaction and ask them, you know, what did you take any new medications or anything like that? Has this ever happened to you before? Maybe in the very same place. Every now and then you can have so much inflammation in there, it may blister and get like some crusting in the center of it. But it's usually, it can be anywhere from asymptomatic to itchy or have kind of a burning discomfort with it. Common sites are the lips, the genitals, and the extremities. But again, it's going to recur in that same spot every time they take that offending medication. Meds that are most commonly cause this type of reaction are your non-steroidal anti-inflammatories. That's what I hear of it the most. Naproxen, especially naproxen, so kind of keep that in the back of your head. Tetracyclines, your sulfa-based drugs, sugar. And there is, I mean, that's just a unique color, you know, you just don't see that color. Lichen planus, which we're going to talk about later on today, tend to have a kind of a purpley color too, and so there's just not too many things that give that violaceous color. All right, so AGEP, acute generalized exanthematous pustulosis. All right, that's a mouthful. Again, every specialty has their 1,002 acronyms, and this is one. They call this AGEP instead of acute generalized exanthematous pustulosis. That's a mouthful. So if you see this, 90% of the time it's due to a medication. You will get more than likely a fever, an acute onset of fever, and your white blood cells are going to go up. So you have some systemic involvement going on. Comes on suddenly, and with this you have non-follicular sterile pustules. So this is not a bacterial folliculitis, although it could look like it, but that's when you need to get close and say, hey, is there a little hair coming out of these pustules, or is it just haphazard? And that will be on top of a diffuse red swelling. All right. As this starts to go away, you're going to notice that peeling action again. When you get that swelling and redness in the skin pretty significantly, as that starts to resolve, it's going to get scaly. About 20% of the time, you can get some mucous membrane involvement, either the groin or the mouth. And those white blood cells will be up in 90%. So that helps you make a diagnosis. And there you go. And those are pinpoint pustules, at least in this picture. So looking at how widespread that is, I'm not gonna. My first thing is not gonna be folliculitis. just because folliculitis isn't usually that widespread. Questions about that? So know that know how it's going to present, what it's going to look like, know that there's going to be some systemic involvement with fever and your elevated white blood cells. All right, now let's talk about hypersensitivity syndromes. And this is called DRESS, D-R-E-S-S, and that stands for drug rash with eosinophilia and systemic symptoms. Okay? So that tells us right there, we're going to have a rash, we're going to have increased eosinophils, and we're going to have systemic symptoms such as fever and what we're going to talk about. So this is going to be kind of a delayed reaction, sometimes up to 2 weeks or even months after the medication was started. One thing to really remember with this is facial edema, especially around the eyes, with lymphadenopathy. Fever, feeling yucky, facial edema, especially around the eyes, and lymphadenopathy. Again, you're going to have that morbilliform reaction, or eruption rather, those tiny, fine erythematous macules and papules that become very generalized. So again, how is this going to be different from just your regular morbilliform reaction? You're going to be a lot more sick with this, or not you, but your patient's going to be a lot more sick with it. Going to have fever, and going to probably have some facial swelling, especially around the eyes, and some lymphadenopathy. Plus, you're going to find they're going to have some abnormalities in their blood work. Eosinophilia, the eosinophils are going to be elevated. Your lymphocytes may be elevated. And liver functions and possibly renal function tests are going to be elevated. Can cause some other pneumonitis inflammation around the heart and lungs. So again, the history and just your clinical, observance of the patient is going to help you make this diagnosis. And then getting some blood work too. You're going to get blood work on somebody like this. Anticonvulsants and sulfa drugs are your most common. You noting that pattern? Okay, got to get that offending drug out of their system immediately. If they have some, if their liver enzymes and or kidney enzymes are elevated, you may want to go, I would strongly consider some oral steroids or steroid shot, but I think oral steroids are better. And sometimes they need to be on a low dose for several months. These types of people you're going to be referring. But you may want to get them started on some steroid or something like that until they get into something else. Again, the rash and the hepatitis or the elevated liver enzymes are going to persist for several weeks. But you've got to educate your patient. You can never go on this medication again, and any other similar drugs in that same class. And tell them to wear some kind of a medical alert, something. So again, you can't tell that rash from the very first morbilliform reaction. It's all history, their clinical presentation, other systemic symptoms. They're going to be a lot more sick with fever, lymphadenopathy, swollen face, and the blood work's going to show some abnormalities.
When these kind of rashes all over the body start, do they usually start in a single area, or do you just wake up and just have this huge rash all over?
Wake up and
okay.
all over.
Okay.
Or at least you know, maybe not this prominent, but
Yeah.
it starts all over and it just gets
Okay.
more confluent.
You wake up and it's all over, that's what I look like.
She had dress syndrome. Was yours sulfa-based?
That's what it's all bad.
Yeah, yeah.
So I'm banned.
You were banned. Never ever.
I went
Yeah,
swimming on
almost all the
sulfa drugs
time.
once, like outside in the sun
Ooh,
for
and
a
you got
time.
the
That's the
sun.
only time I ever had, but we were watching a movie and I was like, man, I'm like feeling itchy everywhere.
I had that too.
Went in the
on
bathroom,
sulfa.
turned on the light, lifted up and it was like head to toe, huge.
Itchy. Different than hers.
Yeah, much
Yeah,
different.
Yeah, much different. So did you tell us about your case? Did you have elevated liver?
Yeah, I was dermatologist, actually, went to a dermatologist and gave me Dapsone, which is sulfa, and it's for a lot of things, but I have celiac disease over my nose and I have a rash that goes along with it, so it was for that. And about day 8, woke up, had a fever, like 102. All my lymph nodes were swollen everywhere. I didn't really have the swelling
You didn't?
in my eyes, but, and my urine was brown,
Wow.
so.
Had renal involvement? Was your liver
Oh,
affected?
off the charts, yeah. So, and then I had the cough.
Pneumonitis?
Yeah,
Oh, yeah.
I had that. And my resting heart rate was 110. So,
Wow.
yeah, so I started on high-dose steroids for 3 months.
Absolutely, absolutely. Well, your body read the book. You followed the directions, that's right. Well, yeah, and that is not your typical just, you know, rash, itchy rash all over. Much more sick.
I look just like that.
Yeah, yeah. So, excellent. All right, now we're going to talk about 3 other types of drug reactions: erythema multiforme, Stevens-Johnson syndrome, and TEN, or toxic epidermal necrolysis. Out of the 3, the erythema multiforme is the least concerning. These are groups of mucocutaneous, so mucous membrane involvement and skin involvement that are potentially blistering diseases. They used to think all 3 of these were kind of on the same spectrum, but now they're kind of taking the erythema multiforme out and have the Stevens-Johnson and TEN kind of on together. Erythema multiforme is kind of an interesting thing. It's not as commonly associated with medications, although it can be. What it's most commonly associated with is an infection, mainly herpes simplex. And it's kind of interesting. I don't know the physiology behind it, but whenever they get an outbreak of their herpes labialis, you know, their cold sore, they start breaking out in this very distinct looking rash. And so it's kind of an interesting thing. It's almost like they're having a reaction to their reaction. But this is an acute onset. It's self-limiting though. 90% are actually caused by infections, mainly that herpes simplex. But it can be drug-induced. Barbiturates, antibiotics, especially sulfa and penicillin, anticonvulsants, and nonsteroidals. Sometimes they don't even have to have a real obvious outbreak. In fact, I had a gal who I got a biopsy because I wasn't quite sure what her rash was, and it came back as erythema multiforme, and there was no history of cold sores or anything like that. And I said, you know, this is most commonly associated with this, so I want to try an experiment, and I put her on an antiviral medication, and her rash cleared up. So kind of I said you may want to, if you start seeing this rash, get on this, you know, as quickly as you can, and just to educate her that it could be, she could have a subclinical flare. Okay, what's interesting about this is that their primary lesion is kind of called a target lesion, okay? Because it looks like a target, right? It has three different zones that I'll show you a picture of. And again, it's very unique, very unique. And erythema multiforme is categorized into EM minor and EM major. And it basically has to do with the mucous membrane involvement. So EM minor, again, self-limited, more so in your young adults, can be recurrent, again, if it's, especially if it's associated with HSV. And it'll last about 1 to 4 weeks. So these lesions are very well demarcated. Again, this target lesion has these 3 zones. You don't necessarily need to know exactly which zone is what, but you'll be able to appreciate it once I show you a picture of it. So this one is kind of against the rules, goes against the grain. This one starts more on the extremities and moves more truncal. With EM minor, you have very little, mainly no mucous membrane involvement. You can oftentimes have, a lower grade fever, feeling kind of yucky arthralgias, but not major. I beg your pardon. EM major has more of the fever and systemic symptoms. EM minor does not. I beg your pardon. I made a mistake there. So again, what differentiates EM major versus EM minor is mucous membrane involvement. It's prominent with EM major. Mainly oral mucosa, but can also be the genitalia or the eyes. And there is that targetoid lesion or target lesion. The central area is more raised. It can't even become a vesicle. And then you have a lighter area, but it's more raised, but not like the center is. And then you have the outer part that's just flat, but red. Here's this. So that looks just like a target, doesn't it? So again, if HSV is associated, treat that HSV or stop the drug if it's a drug related. You can treat oral antihistamines to help with any itch, topical steroids, again, for symptom relief. Talked about the acyclovir, either intermittent treatment or suppressive treatment. If they're just getting this, a flare of their herpes simplex and then getting this rash every time they break out with a cold sore, then you may want to put them on suppressive daily treatment. For EM major, when they have more of the mucous membrane involvement, you may want to give them some kind of a swish and spit with lidocaine and Benadryl. Any eye involvement, refer to an ophthalmologist. And just, again, dehydration with the oral involvement, push that. If they get dehydrated or just not able to get any fluids in, you may need to give them some fluids. All right, and then the big guns are bolus drug reactions, are Stevens-Johnson and TEN, T-E-N. Toxic epidermal necrolysis. These can be life-threatening. And mucocutaneous, so mucous membrane as well as skin involvement. And they have extensive of both, can be extensive of both. They will just lose their skin in sheets like it's been a burn victim. Now, how you tell the difference, the presentation is really going to be pretty much the same. The definition is in how much body surface area is involved. If it's Less than 10%, it's called Stevens-Johnson. If it's 10 to 30% skin involvement, it's kind of an overlap between the two. If it's greater than 30%, it's going to be TEN. So you probably want to kind of remember those numbers for at least my test. So sometimes you don't know what causes this, but by far the most common is a drug reaction. Again, HIV, if you have a secondary viral infection associated, you're at even greater risk. There have been a lot of medications, over 100, that have been implicated in the cause of this rash. Trimsulfa. Shocker. So you can see why I'm a little bit more leery to prescribe Trimsulfa or Bactrim just willy-nilly. I will if I need to, and if I know they've been on it before and they haven't reacted, but I'm cautious. In children, your sulfa-based drugs, anti-epileptics, Tylenol, oddly enough. So presentation of this can be anywhere from a few days to a few weeks after the offending agent. And you're going to have a prodrome of fever and flu-like symptoms for a few days before the rash starts. You may even too have kind of signs of, you're not going to have an overt sloughing of the mucosal membrane, but you may be able to tell in retrospect that something was kind of brewing. You may have a little bit of signs of irritation, a little dysuria, conjunctivitis, a little discomfort when you swallow, days before the rash starts. So it's going to start on the face and trunk and spread, and it spreads rapidly. And this is painful. This is not itchy. This is painful. And this can look a lot of kind of different ways. Just diffuse redness. Blister may have some target lesions like the erythema multiforme, and blistering. Blistering is going to be key, and then that's going to just slough. Usually you have 2 or more mucosal surfaces that are involved. Your most common to be involved are the eyes and the mouth. You will be able to see this Nikolsky sign, and I would be familiar with what this is. This is where the skin will easily peel away. Okay, that epidermis will kind of peel away. And what you can do is just kind of give lateral pressure on the skin, kind of like what I'm doing here, and it'll just kind of peel off. Okay? That indicates that that upper epidermis is just peeling away. It's easily separating from that lower epidermis. Sheet-like loss of skin. Again, the mucosal involvement is extensive, so they are not drinking, not eating. It's bad news. You want to get a biopsy. Again, you're going to, family medicine or whoever is not going to be managing this. You're going to send this off. A biopsy will obtain. The best place is kind of that leading edge of a blister. And there, see, you just see that widespread blistering, and then it just sloughs. I mean, that's like a burn. Horrible. Obviously, you got to get that medication off board. You treat them like a burn victim. They need lots of IV fluid replacement, wound care, because they just have, their skin integrity is just gone. So they're at really great risk of getting secondary infection, and sepsis is the main cause of death. But there is a big mortality rate, okay? 10% with Stevens-Johnson, when you have a combined, it's 30%, with TEN, almost 50%. So half of the people that get this are going to die from it. If they survive, the most long-term sequelae or complications are with the eyes, so you need to get them referred to an ophthalmologist. Okay, pretty bad stuff, huh?